Hello and welcome to my second ECG basics video. So in this one, we're going to talk about a system for reading an ECG, 6 simple steps to interpret a 12-lead ECG. And then I'm also going to talk about 6 simple steps within that to interpret your rhythm strip. So let's get started. The first thing you're going to check on your 12-lead ECG is the patient's details. So have a look, make sure it's the right patient before you get started. Really important. Sometimes, of course, it's possible for us to be handed an ECG with no patient details, and make sure that you get that corrected. Second, we really want to know what the indication for the ECG is. Now, if you're looking at this as part of an exam, you may not always be given the indication, but I think it's good practice to ask. In clinical practice, you can always find out a bit about the clinical context, and it really matters. Is this a patient with acute chest pain presenting to the emergency department? Or is this a patient in an outpatient clinic who maybe has chronic kidney disease? That context is going to influence how you interpret the ECG because it affects the pre-test probability. The abnormalities that you might find are exactly what they are, but the way you interpret those will change according to the clinical context. Third, have a look at the type of ECG. So is this a standard 12-lead ECG? Is it a rhythm strip? Is it a 15-lead ECG? Do you have posterior leads? Do you have right ventricular leads added in? And what's the format? What have you got? One of each lead from the 12-lead ECG and a rhythm strip? That's the standard. Or is it an alternative format that you're looking at? Next, we're going to look at the rhythm strip. Usually that's from lead 2, and usually that's at the bottom of the ECG. So take a look at the rhythm strip, and we'll need our own system for interpreting the rhythm strip. After that, we want you to look at the 12-lead ECG itself, interpret the axis of the ECG, and I will cover that in a future video, how we interpret the axis. Lastly, look at each lead individually. Go through them systematically. Have a look at each of the 12 leads. Now, as you look at more ECGs, you'll actually get better at knowing what each lead should look like. Should the P wave, QRS complex, and T wave be upright, or is it normal to have them inverted? Should you have a Q wave, or should you not have a Q wave? You get to know all of those things as you look at more ECGs. And when you interpret a 12-lead ECG, you should be looking at every single lead to see if it fits with what you understand as a normal pattern. So let's say that we've checked the patient details, the indication, and we're onto the type of ECG. Now, this 12-lead ECG, we want to look at a couple of things. This is obviously a 12-lead ECG, and we can notice that it's quite old, but it's here to demonstrate 2 important points. First of all, the calibration. So every ECG should have the calibration plotted on the left-hand side here. Now, to interpret that, you need to look here at the bottom of the ECG, where we can see 2 things. We can see the speed of the ECG. Here it's 25 millimeters per second, which is standard. You might see ECGs recorded with 50 millimeters per second. Someone might have altered the settings because they want to have a close look at a particularly fast rhythm, for example. So just double check that it is 25 millimeters per second. If, of course, it's been changed, it will affect how you interpret all of the intervals on the ECG. Next to that, you can see this 10 millimeters per millivolt statement, and that relates to the calibration of the ECG. So for every 10 millimeters, that represents 1 millivolt of deflection. Now, that relates to this calibration plot on the left here. And what you can see, you should see 1 millivolt represented. So this plot should be 10 millimeters if the ECG is well calibrated. So that's 2 of the bigger squares, of course, 1 centimeter on the ECG. And then you can just make sure that that ECG is well calibrated. Once we've looked at the type of the ECG, we can start to look at the rhythm strip. And now I've got 6 more questions that we're going to ask that will help us to interpret every rhythm strip that we look at. So first of all, is there any electrical activity at all? If there's not, you'd be a bit concerned. The most obvious explanation is, of course, that a lead has been disconnected. Most modern ECGs will give you just a dotted line if the ECG lead is disconnected. Some will give you a very straight line. Now, a very straight line is unlikely to be asystole. Patients in asystole just have a slightly wandering baseline. Of course, if you saw that, then that's a problem straight away. So go and check your patient. If you have got electrical activity, ask what the ventricular rate is. Now, most ECG machines will give you the rate. They'll have calculated it. But you can calculate it, of course, for yourself. There are many different methods of doing that. You could, for example, count the number of big squares in between two complexes, QRS complexes, and calculate 300 divided by that number, and that will approximate the rate. Now, you may need to go to more than that. Of course, if you've got an irregular rhythm, you may need to look at the gap between 4 QRS complexes and do 900 divided by that amount if you want to calculate it for a less regular rhythm. Third, we want to know, is the QRS rhythm regular or irregular? If it's regular, that's fine. You can stop there. That's all you need to know. If it's irregular, we need to think, well, how is it irregular? Is it that this is a pattern? There are some missing beats, for example. It's regularly irregular. Or is it irregularly irregular, in which case there's absolutely no pattern and we can't predict when the next beat is going to come. So try and have a look at that and decide if it's regularly irregular or irregularly irregular. Now, that's where you might, of course, need to run a piece of paper at the bottom and plot where the different QRS complexes are, running along and see if you can spot the patterns and the regularity. Fourth, is the QRS complex narrow or broad? Really important. Of course, we want the QRS complex to be narrow. That's normal. If it's broad, it's going to get us starting to think about certain abnormalities. Could it be a bundle branch block? Could it be that the patient's paced? Could it be that the patient has an electrolyte abnormality or another reason for a broad QRS complex? Could it be that they have a heart block? It narrows down our differential diagnoses, but it certainly spots an abnormality and makes us think in certain ways. Number 5, have a look to see if there's any atrial activity. Now, if there is some atrial activity, have a look at what it is. Is it normal P waves? Are they funny shaped P waves? Are they large P waves? Are they inverted P waves? Have a look at that atrial activity and try to articulate what it is that you're seeing. And then lastly, have a look at how that atrial activity is related to ventricular activity. So of course, we should see a P wave followed by a QRS complex every time. This is where you might think about the intervals though. Is the PR interval too long or too short? Is every P wave followed by a QRS complex? Is the PR interval constant or is it lengthening? Are there any dropped beats? So that's the kind of thing you want to look at with the 6th question. With those 6 questions, I think you can pick out every single rhythm that you might see on the rhythm strip. So lastly, let's just talk about ECG intervals. Now, there's a number of intervals that we will want to have a look at. There's the PR interval, and we measure that from the start of the P wave to the start of the QRS complex. Normal is 3 to 5 small squares. So you know that each small square is 40 milliseconds. That means the normal PR interval is between 120 and 200 milliseconds. Next, we'll look at the duration of the QRS complex, and that's usually pretty obvious. It's the start of the Q wave to the end of the, whatever the end of the QRS complex is at the J point. And that should, of course, be less than 3 small squares, so less than 120 milliseconds. Lastly, we've got the QT interval. So that runs from the start of the Q wave to the end of the T wave. Now, normal is in the range of around about 380 milliseconds to 460 milliseconds. From a practical perspective, what you need to know is, well, number 1, this varies with the heart rate. So the faster your heart rate, the shorter your QT interval. And there are lots of formulas available to correct for heart rate. Now, most ECG machines will automatically present the QTC, the corrected QT interval. If it doesn't, and if you need to work out that QT interval, as a general rule of thumb, you can have a look to see if there are more than 2 small squares between the complexes. So that, of course, is around about 400 milliseconds. Now, that's going to be around about normal for a patient with a heart rate. If it's substantially smaller than that, you might have a short QT, substantially longer, and you're going to be thinking that the patient has a prolonged QT interval. So that is actually where I'm going to stop today. We're going to pick up some more on rhythm strips, and we're going to have a look at some common abnormalities and how we can pick them out using the system that we've been through today. Thank you very much.